Welcome to the deep dive. You've given us, well, quite a mountain of clinical sources this time,
We have indeed.
covering acute heart issues, chronic conditions, blood disorders. It's a lot.
It is.
So our mission today is simple. Cut through it all. We want to pull out just the crucial, the really actionable knowledge about cardiac emergencies, pump failure, blood flow problems.
Basically how it all connects.
Exactly. For you listening, the goal is quick absorption of what you really need to know.
Yeah, and the sources give us a great clinical framework. We're moving from those really lethal electrical emergencies right through to long-term systemic conditions.
And the drugs and tests used along the way.
Right. The challenge, I think, is always synthesizing the what, the symptoms you see with the why.
The underlying pathology.
Exactly. What's actually going on inside.
Okay, let's dive right in at the deep end. The electrical system. High stakes. Ventricular fibrillation, VFib. What makes it the lethal emergency?
Well, VFib is it's total electrical chaos. Multiple spots in the ventricles are firing off randomly. The heart muscle isn't contracting.
It's just quivering.
Precisely, fibrillating. So on the monitor, you see this completely disorganized, wavy line. Right. Unknown. P waves, QRS complexes, not identifiable.
And critically, no pulse. No heart rate you can actually measure.
Which means instant cardiac arrest, zero blood flow.
Hence the urgency. CPR, oxygen, and DFIB. Defibrillation. Like now.
Absolutely. There's no time to waste. You need to shock the heart back into some kind of rhythm.
Okay, contrast that with VTAC, ventricular tachycardia. Still serious, but different.
Very different initially, at least. VTAC is fast, yes, rates usually 100 to 250. And the QRS complexes are wide, bizarre looking. People sometimes call them tombstones.
But it's organized.
It's organized, albeit dangerously fast and inefficient. The crucial distinction, the absolute key thing, is the pulse.
VTAC can have a pulse.
It can. If there's a pulse, you might manage it with medications first. But VTAC without a pulse.
You treat it just like VFib. CPR, shock.
Exactly the same. Because functionally, there's no cardiac output.
And of course, untreated VTAC often deteriorates.
Straight into VFib, and then potentially a systole, the flat line, death.
Okay, so those are the immediate life threats. What about the non-lethal but still high-risk rhythms?
Yeah.
Like AFib, atrial fibrillation.
So right, AFib is incredibly common, especially as people age. It's not immediately lethal like VFib.
But the risk profile is huge, isn't it? The
Yeah.
sources really hammered this home.
They did. In AFib, the atria aren't contracting properly. They're just quivering, sometimes hundreds of times a minute. So blood doesn't get pushed through effectively. It pools.
And pooled blood loves to clot.
Exactly. That's the danger. Those clots can form in the atria, break off, and travel anywhere.
Lungs causing a pulmonary embolism.
Or the heart itself causing an MI.
Or, very commonly, the brain. Stroke,
Yeah.
CVA.
Yeah, unmanaged AFib is a major, major risk factor for stroke. It's a systemic threat, not just cardiac.
Before we leave rhythms, that hard reboot drug for SVT, supraventricular tachycardia, adenosine, it's quite dramatic.
Oh, it really is. SVT is when the heart's beating way too fast, originating above the ventricles. Adenosine works incredibly quickly.
You push it fast, Bobby.
Super fast push. It has a half-life of like 10 seconds.
Yeah.
And for that brief moment,
It stops the heart. Asystole.
brief asystole, yes. You see a flat line for a few seconds. It feels like forever when you're doing it.
I bet.
The hope is that the heart's own natural pacemaker, the sinus node, will kick back in and reset to a normal rhythm. High stakes, but effective.
Okay, let's shift gears. From the wiring to the plumbing. Coronary artery disease, CAD. Let's unpack the basic pathology.
Sure. So CAD is fundamentally about atherosclerosis. That's the buildup of fatty plaques inside the coronary arteries, the ones that feed the heart muscle itself.
So the pipes get clogged.
Essentially, yeah.
Okay.
They narrow, harden. This restricts blood flow, especially when the heart needs more oxygen, like during exertion.
And that causes the chest pain, angina.
Right. Now, what causes the plaque? That's where the chronic stuff comes in.
The risk factors. I saw the acronym SODA used in a few places.
Yeah, it's a decent mnemonic. SODA. Stress, stimulants, smoking.
O for obesity.
D for diabetes, diet, and definitely hypertension. High blood pressure is a huge one.
And A for.
Often cited as African-American males over 50 having a higher risk profile. But really, those first factors, stress, smoking, obesity, diabetes, hypertension, they damage the artery walls, promote inflammation.
Making it easier for plaque to build up. So CAD is often secondary.
Very often. It's a consequence of these other long-term, often lifestyle-related conditions not being managed well.
Okay, so if someone has angina, we need to know if it's stable or unstable, right?
Crucial distinction. Stable angina is predictable, comes on with exertion, goes away with rest, or maybe nitroglycerin. The blockage is there, but it's, well, stable.
Unstable angina.
That's different.
That's the warning sign. It occurs at rest, or it's suddenly much worse, more frequent. It means the plaque might be unstable, maybe ruptured. That's often called pre-infarction angina.
Because it signals an MI might be imminent. Exactly. A myocardial infarction, a heart attack. That means a complete blockage, usually from a clot forming on a ruptured plaque. Heart muscle downstream starts to die from lack of oxygen.
And the classic MI symptoms. Sudden crushing chest pain.
Yeah.
Radiating.
Yeah, often radiating to the jaw, the left arm, sometimes the back. And critically, it doesn't go away with rest or nitro.
But we need to be careful here, don't we? Especially with certain populations.
Absolutely essential point. Women, older adults, people with diabetes, they often don't have that Hollywood heart attack presentation.
What might they experience instead?
It can be much vaguer. Extreme, sudden fatigue, shortness of breath that comes out of nowhere, or maybe discomfort, not crushing pain, but discomfort in the shoulder blades or the middle of the back, even jaw pain alone.
So missing those could be disastrous.
It really could. You have to have a high index of suspicion based on risk factors, not just the classic pain.
Okay, MI is suspected or diagnosed. Treatment often follows MONA.
MONA is the classic mnemonic, yeah.
Huh?
Morphine, oxygen, nitroglycerin, aspirin. Though the order isn't always strict.
Oxygen first usually, right?
Often, yes. But clinically, the real immediate priorities are often aspirin and nitro.
Why aspirin first?
Antiplatelet. Stops the clot from getting bigger right away. Chewing it works fastest.
Okay. And nitro.
Vasodilator. Opens up the arteries, trying to improve blood flow and reducing the heart's workload. Morphine helps with pain, which also reduces cardiac demand and anxiety.
Makes sense. And
Yeah.
how do we confirm actual heart muscle damage has occurred?
The gold standard biomarker, troponin levels.
Okay. Explain troponin.
It's a protein found in heart muscle. Normally, it shouldn't be detectable in the blood. 0 is the baseline.
So any elevation means?
It means heart muscle cells have died and released their contents into the bloodstream. Any elevation needs evaluation. Rising levels confirm an acute MI. It's definitive.
Got it. Let's move to chronic weakness now. Heart failure. HF. The pump itself is failing.
Right. HF means the heart ventricles can't effectively fill with blood or eject blood or both. The pump just isn't keeping up with what the body needs.
And there's a key blood test here too, isn't there? BNP.
Yes, brain natriuretic peptide. The ventricles release BNP when they get stretched too much, usually due to fluid overload and pressure.
So it's a measure of stress on the heart.
Exactly. Normal BNP is very low, like under 100 pgml. In mild HF, it might be 300. But if you see levels climbing towards, say, 900 or more,
That's severe failure. Decompensated HF.
definitely.
Yeah.
It tells you the heart is under significant strain. Another key measure is ejection fraction, or EF.
Right. Measured usually by echocardiogram.
Yep. It's the percentage of blood the left ventricle pumps out with each beat. Normal is pretty good, like 55–70%.
And below 40%.
Below 40% is indicative of significant systolic heart failure, really poor pump function.
Okay, and HF presents differently depending on which side of the heart is failing most. Right, left versus right.
Correct. It's about where the fluid backs up.
So, left-sided failure. The backup is before the left ventricle, meaning...
Meaning back into the pulmonary circulation, into the lungs.
So all the symptoms are respiratory. There's that acronym, drowning.
Yeah, it helps remember D for dyspnea, shortness of breath, R for rales, crackles, you hear it in the lungs, O for orthopnea, can't breathe lying flat.
W for weakness, N for nocturnal paroxysmal dyspnea, waking up suddenly breathless.
I for increased heart rate, try and compensate, N for nagging cough, often with frothy or pink-tinged sputum.
And G for gaining weight from fluid. Basically, the lungs fill with fluid.
They're effectively drowning, yes.
Okay, then right-sided HF. The backup is before the right ventricle.
Meaning back into the systemic venous system, the body.
So the symptoms are body-wide fluid retention. The other acronym, swelling.
Right. S for swelling of the legs, hands, feet. W for weight gain, rapid weight gain. E for edema, pitting edema usually.
L for large neck veins, jugular vein distension, JVD. L again for lethargy.
I for irregular heart rate, often AFib coexists. N for nocturia, peeing a lot at night as fluid shifts when lying down. And G for girth, increase ascites, fluid in the abdomen.
So left is lungs, right is rest of body.
That's a good simple way to think about it.
For patients managing chronic HF at home, What are the key nursing takeaways?
Daily weights are absolutely critical. Same time, same scale, same clothes every morning.
Why is that so vital?
Because a sudden gain of, say, 2 to 3 pounds in a day or maybe 5 pounds in a week isn't fat, it's fluid. It's an early warning sign the HF is worsening, that they're retaining fluid, and they need to call their doctor or clinic, maybe adjust diuretics.
Before they end up really breathless.
Exactly. Early intervention. Also, elevating the head of bed, HOB, helps with breathing, especially at night, by reducing fluid return to the heart and pressure on the lungs.
Makes sense. Okay, let's broaden out slightly. Systemic perfusion issues.
Hmm.
How does the blood itself affect things? Anemia, for instance.
Anemia fundamentally means not enough healthy red blood cells to carry sufficient oxygen to the tissues. There are many types, but the result is fatigue, weakness, shortness of breath.
Because the oxygen delivery system is impaired.
Right, and a particularly dramatic example is sickle cell anemia.
Here, the problem isn't just the number of red cells, but their shape.
Exactly. It's an inherited disorder where red blood cells, normally round and flexible, become distorted into a rigid sickle or crescent shape, especially under stress or low oxygen conditions.
And these sickled cells cause problems.
Big problems. They're stiff, sticky, they clump together and block small blood vessels. This is called a vaso-occlusive crisis.
Blocking blood flow. That means ischemia downstream.
Right. Lack of oxygen to tissues and organs. And this causes severe, often excruciating pain. It can also damage organs over time.
How do you treat a sickle cell crisis?
The cornerstones are HOP, hydration, oxygen, pain relief. Aggressive 5e fluids help dilute the blood and flush the vessels. Oxygen can sometimes help. And pain control is paramount, often needing strong opioids, sometimes via PCA, patient-controlled analgesia.
And long term.
There are medications like hydroxyurea that can help reduce the frequency of sickling and crises. Patient education about avoiding triggers like dehydration or high altitudes is also key.
Okay. Briefly, hemophilia.
Another inherited disorder, but this one affects clotting. People lack specific clotting factors. Factor 8 for hemophilia A, factor 9 for hemophilia B.
When they bleed easily and excessively.
Correct. Treatment involves replacing the missing factor intravenously, either to stop a bleed or preventatively. The big thing is teaching patients and families how to avoid trauma, no-contact sports, being careful with injections, dental work, etc.
Got it. Now let's connect blood flow issues back to the brain. Stroke, CVA.
Yeah, cerebrovascular accident. Many of the same risk factors for heart disease apply here.
We need to distinguish TIA from CVA, right?
Absolutely. A TIA, transient ischemic attack, is like a mini stroke. There's a temporary blockage, symptoms occur, but blood flow is restored quickly and there's no permanent damage. It's a huge warning sign, though.
Whereas a CVA involves actual brain tissue death due to prolonged lack of blood flow, ischemic stroke, or bleeding into the brain, hemorrhagic stroke.
Correct. And the number one cause, especially for hemorrhagic but also ischemic,
Hypertension.
uncontrolled hypertension, definitely. Systolic pressure, consistently over 140, puts immense strain on those delicate brain vessels. Smoking, high cholesterol, uncontrolled diabetes, AFib, they're all major players too.
And the warning signs, fast.
Fast, face drooping, arm weakness, speech difficulty, time to call 911. Everyone should know those.
For ischemic stroke, time is critical for treatment, isn't it?
Incredibly critical. If it's an ischemic stroke, a clot-busting drugs, thrombolytics like TPA, tissue plasminogen activator, can potentially reverse the damage.
But there's a window.
A very narrow window, usually within 3 hours, sometimes up to 4.5 hours, from the onset of symptoms. That's why recognizing symptoms fast and getting to the hospital immediately is vital. Time is brain.
And TPA isn't for everyone.
Definitely not. You can't give it if someone's had recent surgery, major trauma, has bleeding issues, or if their blood pressure is sky high. The risk of causing a severe brain hemorrhage is too great. Careful screening is essential.
Okay, tying this all together. Diagnostics and drugs. If you had to pick 2 absolutely crucial diagnostic tests from all this material.
Ooh, tough choice. But I'd have to say, number 1, cardiac catheterization or angiogram.
Where they thread a catheter up to the heart.
Yeah, usually via an artery in the wrist or groin. They inject dye and take x-rays to visualize the coronary arteries directly, see exactly where blockages are. It's diagnostic, and they can often intervene right then with angioplasty or stents.
And the critical post-procedure checks.
Gotta watch that access site for bleeding or hematoma. Crucially, check pulses distal to the site, like the pedal pulse, if they went through the groin, to ensure blood flow wasn't compromised.
And the really dangerous complication.
Retroperitoneal hematoma. Bleeding behind the abdominal lining, it's sneaky.
What are the signs for that?
Sudden, severe, often one-sided flank or back pain, and signs of shock blood pressure dropping, heart rate shooting up, maybe bruising appearing later. It's an emergency.
Okay. Diagnostic test number 2.
I'd go with the stress test. Evaluates how the heart handles increased demand.
Either by walking on a treadmill or using medication.
Right. Meds like dobutamine mimic exercise effects. You monitor ECG, blood pressure, symptoms.
And the absolute rule for stopping a stress test.
Stop immediately if the patient reports chest pain, significant shortness of breath, dizziness, blurred vision, or if their vital signs deteriorate badly like BP plummeting or dangerous arrhythmias appearing. Safety first.
Good points. Now, key drug class warnings. Let's nail down 2 big ones. Beta blockers. The OLALs. Metoprolol, atenolol.
Okay, beta blockers slow the heart rate and lower blood pressure. So the big hold parameters do not give if the heart rate is less than 60.
Or if systolic BP is less than, say, 90 or 100.
Generally, yes, check your specific order, but typically hold for SBP less than 90 or 100. And the other key thing, caution with asthma or COPD.
Why is that?
Non-selective beta blockers can also affect beta receptors in the lungs, causing bronchospasm or constriction. So use with caution or choose cardioselective ones.
Got it. Second big drug class, ACE inhibitors, the secebrals, lisinopril, and alapril. Cornerstone drugs for HTN and HF.
Absolutely. They work wonders for many. Common side effect everyone knows is that persistent, dry, nagging cough. Annoying, but not dangerous.
Look, there is a dangerous one.
There is angioedema. It's rare, but potentially fatal.
What is it?
Swelling, typically of the lips, tongue, throat. If the tongue swells, if the airway swells.
Airway compromise. Emergency.
Immediate emergency.
Yeah.
Stop the drug, secure the airway. It's a high alert side effect you always have to watch for, especially when starting the drug.
Wow. Okay, that was a really dense, targeted synthesis. We hit the big 3 systems. Electrical, pump, and plumbing.
Yeah, the electrical crises like VFib, the chronic risks like AFib, then the pump failure measured by BNP with left versus right symptoms, and the plumbing issues of CAD, MI, and stroke.
The MO&A treatment, troponin, fast signs, TPA window.
And those key diagnostics like cath lab checks and stress test rules, plus the big warnings for beta blockers and ACE inhibitors.
So if you had to give one overarching insight from connecting all these dots?
It's the interconnectedness. And maybe more importantly, how often acute disasters are the end result of unmanaged chronic conditions. Meaning that massive heart attack or debilitating stroke often didn't come out of nowhere. It was frequently preceded by years of untreated or poorly controlled hypertension, or maybe undiagnosed AFib, or progressing CAD driven by diabetes and lifestyle. Prevention and chronic disease management are key.
A powerful reminder. Well, thank you for joining us on this very essential deep dive.
My pleasure. It's crucial information.
It really is.
And maybe a final thought for you to mull over, something we didn't explicitly cover but underpins everything electrical.
Go on.
Given how much the body relies on electrical balance, what's the real impact of seemingly minor chronic electrolyte imbalances? Think about potassium and magnesium specifically. How much do those subtle shifts contribute to the irritability that can eventually trigger lethal arrhythmias like VTAC and VFib?
Oh, so baseline chemistry's role in preventing electrical chaos.
Exactly. Something to consider. How fundamental is that electrolyte balance in keeping everything stable?